This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I'm still your host, Dr. Tony Tarchichi. For those of you who are new, welcome. I'm a MedPeds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh. We've been coming to you from the Paul C. Gaffney Division of Pediatric Hospital Medicine with this podcast since about October of 2016, kind of walking our way through pediatric hospital medicine, the content specifications. And I have been avoiding this episode for a while because, well, I'm just going to come out and say, I do not like the new asthma guidelines. I have never liked them. We are not friends at this point. And I have been trying to figure them out. And I said, you know what? We just have to bite the bullet here. We have to do this. And I'm going to bring on one of the experts in our institution on this, who happens to also be a friend, and she can help me figure out what is going on, and then walk me through my distaste for this new guideline. So we're going to start and introduce our expert. We are privileged to have Dr. Allyson S. Larkin, who's a specialist in pediatric and allergy and immunology, and fellowship program director in allergy and immunology here at UPMC Children's Hospital of Pittsburgh. She's an associate professor of pediatrics at the University of Pittsburgh School of Medicine. Dr. Larkin received her medical degree from the University of Pittsburgh School of Medicine. She then completed an internship and residency in internal medicine at Jefferson University Hospital, followed by a fellowship, an advanced fellowship in allergy and immunology at UPMC Children's Hospital. She's a fellow MedPeds person. She has a clinical interest in pediatric severe asthma and established and co-directs a difficult-to-treat asthma clinic at UPMC Children's. Dr. Larkin is a member of the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and Immunology, the Pennsylvania Allergy and Asthma Association, and the Pennsylvania Medical Society. Dr. Larkin, thank you for joining us.
Thank you so much for having me and for this really kind introduction. And I love the thoughts with the intro. I am going to get you to love these and
Okay,
understand them, and we're going to work through this, and this is going to be great.
You got a big job ahead of you. So let's
so
do
excited.
let's do our conflict of interest statements, because we are a CME podcast. I will go first and kick it out to you, Allie. I have nothing to disclose.
I don't have anything to disclose either.
So, Allie, I'm going to start with my first question. It's a broad one. Why was there these changes in this, and why was there a need for a new guideline update for this?
So it's really an amazing time when we think about discovery in asthma, and so many new understandings of mechanisms and new treatment options, even for the most severe asthma, which actually is not part of these guidelines, but tremendous progress with our understanding of how to care for patients with asthma. Our guidelines from the NIH have not been updated since 2007, Tony. So that is why we needed a new set of thoughts. It's been 15 years since published guidelines came out again. So I'm gonna start there and just say it's been a really long time, so we're overdue, and now we've got a lot to look at and cover. And I'll say, as we talk about these guidelines really only cover 6 topics. So when we think about all the things we need to think about in asthma, this is a very, very specific update as we think about this together on 6 very specific topics. So it's not comprehensive in any way, and the guidelines tell us that in the intro. Just 6 topics.
Okay. All right. Now, do you want to walk us through this? How should I approach this?
Yeah. So I'd like to maybe point out where I think there's a lot of impact with regards to changes with the guidelines for folks that take care of children in the outpatient setting. And then I think in the inpatient setting, what you'll see are new treatment regimens. So you may not be changing your inpatient management for kids that are coming in with exacerbations, but you may hear that they are doing different things to care for themselves prior to getting admitted to the hospital or presenting to the emergency room. So the topics that I think are most relevant to those that care for kids are the intermittent inhaled corticosteroid use. And then, we can touch on a few other things. I'll name the other topics, but again, I think the biggest focus and the biggest paradigm shift and the thing that's kind of rocking everybody's thoughts on this is the use of intermittent inhaled corticosteroids and the use of combined intermittent inhaled corticosteroids plus long-acting beta agonists.
Yes.
So that's really, I think that's got everybody's attention. But I'll say, for the sake of completion, that the other portions of the guidelines talk about indoor allergen mitigation, immunotherapy, fractional exhaled nitric oxide, the use of long-acting muscarinic antagonists, and bronchial thermoplasty. And again, I think just to circle back and refocus us on these guidelines that now are updated in 2020, last done in 2007, the thing that's rocking us, I think, is this intermittent inhaled corticosteroid category. So we could definitely focus there, and then we can go wherever you want to go after that.
Well, I mean, I think that's a great place to start because, as you know, I mean, I was trained in a way that you use inhaled corticosteroids as a controller. You don't use it during acute exacerbations. But I remember distinctly patients telling me, or parents telling me for their kids, it helps them during an acute attack. We use it during an acute attack. And we would sit down and have these conversations that it's a controller medicine that keeps you out of the hospital. And then these guidelines come along and those patients were right. Is that right?
Yes, it's phenomenal. And I think folks that have been in practice for a long time are reflecting just how you're reflecting. Wow, this is amazing. We heard this before. We heard this from our patients.
Yeah.
There's sort of a time and a place for that from an evidence-based medicine standpoint embedded in the guidelines. And we can walk through that. But yes, there is now use from an evidence-based medicine standpoint on as needed inhaled corticosteroids. Very true.
So now, how should I, if I have a patient who's coming in, and we've had this where patients come in with a severe asthma exacerbation, maybe it's their first or second time ever needing albuterol, but they were in the ICU, they were quite ill. Do I send them out with an inhaled corticosteroid? Is it just PRN, or is it for preventative use as well still?
Yeah, so that is such a great question, thinking about severity of asthma, which leads us into how these guidelines are described. And for me, the easiest way to think about where these guidelines come into place is to think about age ranges. And we've learned that before, right? So we've had charts on 0 to 4, 4 to 11, and 12 and up. We've all seen those. So we can walk through, if you want, each section in these age ranges and kind of think about where the changes in therapy are for each age range and what that means. And it's so true when we think about your patient who's coming in and went to the ICU with such great impairment. I think that's a child where we might be thinking about controller therapy because the impairment was so big with the admission and the illness. I think as folks think about these guidelines with the intermittent inhaled steroid use, starting in your head in an age bracket may help focus how you use the recommendations. So I think what the emergency room folks may be seeing and what hospitalist physicians may be seeing if we start in the 0 to 4 group are kids in this age group with recurrent wheezing. So they're not quite with you yet, and they're not quite in the ER yet. So they're with our pediatrician colleagues. These kids can now use a short course of daily inhaled corticosteroids on this as needed basis during an upper respiratory tract infection. So you may be seeing kids who are coming in and telling you, for the past 2 months, 2 times, 5 days in a row, I tried my inhaled corticosteroid for 5 days with albuterol, and it's not working. And now I'm here in the ER, and now I'm here in the hospital. I think that's the perspective that you'll see in this young age group. The outpatient folks like myself and like my general pediatrician colleagues are going to see the kids coming in to the outpatient office with a first-time cough or wheeze, toddlers who are doing that with an ear infection. And these kids, so recurrent wheezing for these kids is defined as 3 or more episodes of wheezing triggered by a respiratory tract infection in their lifetime, or they've had 2 episodes in the past year and they're asymptomatic in between. So these are not young toddlers on controller therapy. They're young toddlers who are struggling with upper respiratory tract infections and coughing and wheezing. The main benefit here in this young age group is to try to prevent multiple courses of oral steroids or chronic inhaled corticosteroid exposure. So by doing this, if we identify kids who are intermittently doing this, who we don't think need a course of oral steroids, who we don't think need controller therapy, we potentially decrease the steroid exposure.
So then broadening this out for us, so if I have a 0 to 4-year-old in the hospital, let's say he's in the observation unit coming up to us for asthma or second episode of wheezing, had an episode in the past and is wheezing again and is admitted, not sick enough to be in the ICU. We're coming in, we're doing our asthma dance where we do Q2, Q3, Q4 hours of albuterol, and I'm about to send them out. Mm-hmm. If they're 3 years old, I can put them on inhaled corticosteroids as needed with upper respiratory tract infections. And that's in line with what outpatient management is now for that kid in that age group.
That is, if I think that's very reasonable if you think that that child is not using albuterol regularly at home, requiring more than 1 oral steroid course prior to coming to see you, where then you would be discharging them thinking they need controller therapy.
So those would be the reasons still to keep them on controller therapy. Albuterol daily usage and or more than 1 course of steroids before they come into the hospital.
Yeah, so going back to their control. So poor control, history of poor control, history of maybe multiple oral steroid courses before you see them. That's a child that I would think, nah, I'm not going to try this intermittent therapy on. This child, I think, needs to be treated a step up because this particular therapy is at step 1 in your scale of treatments. So the child with a couple of courses of steroids, maybe an ER visit, albuterol use multiple times throughout the month is going to be classified as having a more persistent, moderate persistent asthma where you'd think about controller therapy. So for this age group, the young kids, we're talking about intermittent step 1 therapy.
Okay. Now, how is that different, or is it different in that same age group if the child went to the ICU, was very ill, had multiple medications on epinephrine, magnesium, Atrovent, really everything? Is that different at all?
So that is truthfully not in not in this particular guideline, but the child that does that for the first time is interesting. I, like you, probably would be worried about how that child might do with the next respiratory tract infection. And I might consider sending a child like that out on controller therapy, or at least to consider it should, they go home and they're using albuterol pretty frequently. It's a tough question. Yeah.
I like this age group that we've divided the patients up with. So are there any other changes in these guidelines for that 0 to 4-year-old that we should know about?
No, I think we're at step 1 in the changes for that particular age group. I don't think you're going to be doing an inpatient intervention there, but you may hear when they come to you that they've tried that and it didn't work, and that's why they're with you.
Okay. Where do we go from here?
Yeah, so we go to our next age group, 5 to 11.
Okay.
And in this age group, the first recommendation is actually a negative recommendation. It's I would not do this scenario. So this first recommendation, and it's a negative recommendation written. So before we had the do this, now when we think about the older kids, 5 to 11, so these kids with mild to moderate persistent asthma, who you have on a daily inhaled corticosteroid therapy, these kids you're not going to do a short-term increase on.
Okay. So you're not going to increase the dosage of their inhaled corticosteroids on a short-term basis.
Correct. So this is the scenario where maybe you have a 7-year-old on low-dose ICS. They need albuterol a couple of times in the winter when they have a cold. They take their ICS regularly, and they start to need more albuterol. And the family says about this 7-year-old who's well controlled on low dose or medium dose ICS, can I just use more puffs of the inhaled corticosteroid? And in this age group, there is not evidence to do this.
Okay. So not go up. All right.
We're not going to go up there, but I'm going to jump for a minute to 12 and up.
Okay.
Because I'm going to tell you now that in this age group on no controller therapy, without hospitalizations or prednisone, so mild persistent asthma, this child can do either daily low-dose inhaled steroids and as-needed albuterol, or this older child can do the as-needed inhaled corticosteroid and short-acting albuterol. So when we think about inhaled corticosteroids, just ICS as needed, your brain has to go to 3 different groups. The really little kids.
Okay. So 0 to 4, I'm going to use it as needed if for upper respiratory tract infections, unless the child is more severe, in which case I still may put it on as a controller.
Yep.
And if they're more severe and I'm the inpatient attending, I'm probably going to refer them to someone like you or in pulmonology to follow them as an outpatient. Or if their PCP is super comfortable doing it, they're PCP. But now you said the 5 to 11-year-old group, if they're on a controller medicine, a low dose inhaled corticosteroid, I'm not going to increase it if they're having exacerbations in the winter or some other with upper respiratory tract infections. It's not going to help. Now, if they're intermittent asthma, am I going to give them PRN inhaled corticosteroids as well? Still?
No.
Nope.
Not that age group.
You're seeing why I'm not a fan of these guidelines.
I know.
Okay.
I know. We have to just wrap our heads around the age group.
Okay.
And think about where these new guidelines are. So the little ones are straightforward. These are the outpatient kids who wheeze with colds a couple times, and they're step 1. They're not severe. They're not moderate. And us folks on the outpatient side will do that. You guys on the inpatient side may see that, but that may prompt you to think, ooh, failed that a bunch of times, got admitted to the hospital, might want to send out on controller therapy kind of thing.
So now, same scenario, 7-year-old comes into the hospital. Let's say he's been in the ED a couple times, and is now admitted with an asthma exacerbation. And I'm going to send them out. Maybe they don't have the best follow-up. Maybe their socioeconomic status is preventing them from seeing a pulmonologist or an allergist. We're going to do our best to help with that. But I want to send them out with something to help the child not come back in. And we're going to talk about limiting environmental triggers, like if someone's smoking at home. We're going to talk about dust mites. We're going to talk about that. I'm going to send that 7-year-old out on inhaled corticosteroids, low dose every day as preventative.
That is absolutely acceptable. That is great care. That is potentially a child who hasn't been doing well, coughing, maybe never even had albuterol, got admitted, but we make this classification that they're persistent for whatever reason in the history. And yes, we send them home on an inhaled corticosteroid. That is very reasonable.
And if they're already on that and they're on albuterol and they're still having exacerbations and needing albuterol regularly, and same scenario, what should I do?
So we're in 5 to 11.
Yes.
And now we're shifting towards what's been called SMART therapy, single maintenance and reliever therapy. But I'll say, before we dive into SMART therapy, it is okay to continue to do what we do. It's going to take a while for folks to incorporate these guidelines, think about these guidelines. And so this is written, when you read this on a piece of paper, what you'll see is alternative treatment and preferred treatment. It is not wrong to continue doing what we do. And for some patients, that may be the easiest, the clearest, and the best way to do it. There are hurdles for SMART therapy, which we can talk about and think about together. But this concept of single maintenance and reliever therapy for mild to moderate persistent disease in age 5 and up in older kids is the thought that you have just one inhaler doing the job of what 2 used to do, right? So in some ways, you are not only helping with asthma control from an evidence-based medicine standpoint, this works, but you don't have to explain to families which inhaler is for what. There's less confusion. They have one inhaler and it's used for rescue, like you would counsel albuterol, and it's used for prevention, like you would use as controller therapy. So there's recommendations here for, so you're at 4 or 5 or up, age 4 or 5, depends on which sentence you read in which place. And you have moderate to severe persistent asthma. You can use this single inhaler, this combination of inhaled steroids and long-acting albuterol. Now, I want to digress for just a minute and stress that what was studied was formoterol. That was the long-acting albuterol version that's studied. So as we all know, there are several products out of combination inhaled corticosteroid long-acting beta agonists. Formoterol has a quick onset of action, and that's what was studied and that's what was used. So we need to be very specific about the product we are recommending. Okay, so you're 4 or 5 or up, you have moderate to severe disease. You can use this in a single inhaler as both combination daily controller and reliever therapy. So let's say you have a 9-year-old who's on inhaled corticosteroid at a medium dose, and they do see you in the hospital. They get admitted. And let's say they had had a course of steroids prior, and now they're admitted, and you're like, okay, what do we do at discharge here? So instead of increasing an inhaled corticosteroid dose, this patient can be offered the equivalent steroid dose combination therapy with single maintenance and reliever therapy use.
Okay.
So one time we talked, we've talked a lot. I've talked a lot about this with folks in different arenas, and sort of changing things at hospital discharge seemed maybe confusing to start smart therapy when somebody's discharged from the hospital. So maybe that's an idea that gets brought to the patient and followed up on in specialty clinic. But to your point, prior to escalating inhaled corticosteroid doses, this is a child that we might want to leave at equivalent corticosteroid dose, but combination, and use it in combination.
Use it, and then they would get rid of their albuterol.
Yes.
Okay.
Yes.
Okay. This is how you're right. I try, and I know my colleagues around the country try not to adjust outpatient medicines on the inpatient side, especially for asthma, unless, like the example we gave, the patient is not getting into the hospital for any number of reasons. They're not getting into the clinic. They're coming into the ER in the hospital primarily for their care, and then we end up being the de facto managers. And we, of course, try to get them to the outpatient clinics with offering any social services support we can, if that's the cause. But this is good to know. All right. Any other changes in that 5 to 11-year-old group that we should know about as hospitalists?
No. So just to recap for 5 to 11, if you're well controlled on an ICS, you can't increase the ICS like you did for the younger kids. And if you're stepping up therapy and you're mild to moderate persistent, you're thinking about this combination therapy before you're even thinking about escalation of inhaled steroid doses.
And can you review, for those who are listening, when you should think about stepping up? What are your criteria for saying, you know what, you've had X number of exacerbations, or this was a whatever, we should think about stepping up your therapy?
Yeah. So we're looking here at components of asthma control.
Okay.
And we're looking at you greater than one exacerbation a year requiring oral steroids. We're looking at how often you're awake at night with symptoms. We're looking at how many times you've been to the ER, potentially needing oral steroids. We're looking at how often you're using your albuterol. And potentially, we're looking at lung function if you're in allergy or pulmonary clinic, and sometimes in outpatient primary care settings.
And you said this already, but I want to stress this. Part of the point of these adjustments is to really decrease the amount of times patients are getting oral steroids on the outpatient side.
Yes, we're trying to minimize. We're trying to minimize impairment and risk. Ultimately, we want less steroid exposure and we want better control.
All right. So should we go to the next age group?
Yeah. So the final age group, we're at 12 and up. And this is a nice kind of synthesis of everything. So I'll remind you that we talked about them when we talked about the really little kids, because at step 2 therapy for 12 and up, it is acceptable to use as needed concomitant inhaled corticosteroids and short-acting beta agonists. This age group, if you're mild and you're persistent, you can. This age group is the same for moderate to severe step 3 and step 4 therapy as your 5 to 11 kids. It's smart therapy, and that's a strong recommendation to use in this age group. And then this one has a step 5 recommendation in your escalation of treatment, which is the addition of the long-acting muscarinic antagonists.
Okay.
Which we didn't have before in that particular age group. So that's probably not something that's going to be done as an inpatient.
I would assume not without a consult of some type.
Yeah, and you may see more of your teens and your adolescents potentially on that type of therapy. But once we get into step 5, step 6 therapy for all of these kids, we're really in another talk and moving into biologic therapy, which I love to talk about, which I would love to come back and talk about. But
Okay.
yeah.
So these older kids, 12 and up, are kind of a mishmash or a conglomerate of the younger kids, in that for step 1 and step 2, I think you said, you can get just inhaled albuterol PRN or inhaled albuterol PRN short-acting beta agonist with a low-dose inhaled corticosteroid as needed. And then, is that right? I got that right?
Yeah, so it's written as step 2 therapy for the older kids. It's written as step 1 therapy for the younger kids. But I'll tell you that in another set of guidelines that we're not talking about, the GINA, Global Initiatives guidelines, there's a push to really use PRN ICS combo. So we'll do that another time.
We'll do another. And the point of these pushes, again, is to lower the amount of oral steroids somebody's getting.
Yeah.
If we can use inhaled and not use oral, why not?
Yes.
But then step 3 and 4 for these older kids, 12 and up, we are using the SMART therapy, which is the combo long-acting beta agonist formoterol that's been studied, and medium-dose inhaled corticosteroids.
Yes, or low dose. So your step 3 is going to be your low dose combo with the formoterol, and your step 4 is going to be your medium dose combo with the formoterol. Okay. Yeah.
And these guidelines, and correct me if I'm wrong, don't really discuss inpatient management.
Correct.
These are mostly outpatient management. So this will affect us on admission and what they're on, and discharge and what they're not on. Mm-hmm. And now around the country, what has occurred is if somebody's on, let's say they're an older kid or a medium kid, 5 to 11 years old, a 7-year-old, 8-year-old, who's on an inhaled corticosteroid every day for prevention, when they get admitted, we stop the inhaled corticosteroid because we're giving them oral steroids, so it'll do the work of both. That's still okay.
Sure. I mean, sure. I don't know how much more benefit you're going to get from keeping somebody on the inhaled other than potentially having them remember not to stop it.
Well, that's fair. That's fair.
That's the only thing I can think of.
Well, Allie, so far this isn't as bad. I mean, these guidelines were, I wouldn't say we're friends, the guidelines, and I'd say we're acquaintances.
Good.
We're getting there. Is there any other changes that you want to talk about?
I think with regards, I'm an allergist, so I like to talk about allergen mitigation and allergen immunotherapy. Testing can be helpful. Interestingly, though, counseling on mitigation, what this guideline is highlighting is that really multiple things need to be done in interventions. So single interventions for a particular issue tend not to be all that helpful. If somebody doesn't have allergies, it's also not helpful to talk about mitigation. So that's highlighted in here. I also wanted to mention that for asthma, subcutaneous immunotherapy has been studied. The sublingual has not been approved for asthma. So there are a couple of sublingual immunotherapy products approved for allergic rhinitis, but when we're talking about links and treatment with asthma, we're talking about subcutaneous. So I would end then by just letting everyone know the only two things I didn't really touch on at all were fractional exhaled nitric oxide use and bronchial thermoplasty, which was part of these guidelines. Fractional exhaled nitric oxide is a breathing test that is a marker of airway inflammation and can help us assess asthma control and how kids are doing. I don't think you'll be doing that on an inpatient side. And bronchial thermoplasty is a process of creating almost like a scar in the airway to stop airway inflammation, which in kids really isn't talked about much at all. So that was just for completion of everything there. Now everybody knows all of the components of the new guidelines. And I think for us, mostly in pediatrics, we're thinking about the intermittent inhaled corticosteroid portion, primarily as areas of paradigm shifts and impact.
And since you brought up allergies, this is how I was trained classically was if you have someone coming in for exacerbations of their asthma every fall and every spring, and they tell you when the flowers bloom and when the grass grows, I get asthma attacks. We've always linked seasonal allergies and asthma. And how I was taught was to get control of the asthma, you have to get control of the seasonal allergies. And so we'd put them on, let's say, a Flonase or a Zyrtec or a loratadine, in addition to their asthma maintenance medicines. These guidelines don't change that. Is that correct?
Correct. These guidelines are saying consider testing when appropriate for allergies, consider testing before committing people to do things like mold mitigation or dust mite mitigation, and that these mitigation interventions that we ask can be expensive and burdensome sometimes. So,
okay. Well, Allie, I think this was great. I really enjoyed this. Thank you for coming on.
Thank you for having me. I hope we're in a better place.
We are in a better place. I think I'm in a better spot, and I'm happy I would love to bring you on when we're going to talk about these immunomodulators for asthma and especially how they would affect us on the inpatient side. I'd love to have you back. Would that be okay?
Yeah, that'd be super. Thanks, Tony. Always good to talk to you.
You too.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.